You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 24th, 2019. This week, aspirin, TPA and stroke, public reporting of outcomes, Impella, QT prolongation, and primary prevention, ICDs. First up is aspirin. Now, aspirin for primary prevention is in the news again. JAMA Neurology published a systematic review and meta-analysis of 13 RCTs looking at low-dose aspirin for primary prevention. The study included more than 134,000 individuals, and the primary endpoint and objective of this study was intracranial bleeding. Now remember, as background, in 2018, not one, not two, but 3 RCTs of aspirin for primary prevention failed to show a net benefit for the former wonder drug. This systematic review and meta-analysis also shed light on the negative aspects of taking aspirin. In relative terms, the aspirin group had a 40% increase in ICH, and in absolute terms, that translated to 2 extra bleeds for every 1,000 patients treated. That's not a huge increase, but multiplying it times the millions of people taking aspirin, that is a whole heap of harm. I highlight this study for 2 reasons. One is to remind us all to educate people not to take aspirin unless they have established vascular disease. But the more important message, I think, is to remember that even our most beloved and accepted therapies must be tested in randomized controlled trials. Dear friends, I urge you to stay skeptical about preventive therapies given to people who have no complaints or no disease. Second topic is a TPA meta-analysis, and the TPA proponents are back at it. First, it was to give TPA early after stroke. Then, it was, okay, let's try TPA a little later, say greater than 4.5 hours. This past week, a group of authors with long lists of financial disclosures published a meta-analysis of 3 neutral TPA studies, Extend and ECOS-4 Extend and Epithet. All 3 of these TPA and stroke trials missed their efficacy primary endpoint. All 3 showed higher rates of intracranial hemorrhage. However, when the authors put the 3 neutral studies together into a meta-analysis, the results showed that there was benefit, as measured by having a good modified ranking scale of 0 to 1. The authors then proclaim, quote, these data reinforce that thrombolysis in an extended time window, out to 9 hours with perfusion imaging selection, is effective. I don't agree. First, 2 of the 3 included trials were terminated early. The odds ratio for intracranial hemorrhage was nearly 10. Now go look at Table 2. The delta, the improvement, was 7% more patients in the TPA arm had a modified ranking of 0 to 1. But remember that modified ranking scale is subjective. Intracranial hemorrhage is not subjective, it's objective. And this was 5% higher in the TPA arm. The authors say 90% of deaths were unrelated to TPA. Okay, that's true. That means that 10% were related. So that is about 5 patients of 200 who died because of TPA. Now, look at the subgroups. When you sort out the results by stroke severity, only NIHSS scores less than 10, mild strokes, did better with TPA. Severe strokes, those with an NIH scale greater than 10, had no difference in the primary endpoint, and there was a significant p-value for interaction in this subgroup. Now, this is exactly what Dr. Jerome Hoffman has argued all along, that the outcome of stroke turns on the initial severity of stroke much more than the therapy. If TPA lysed clots, why does it work only for patients with mild impairment at baseline? Now, all of these criticisms are less than the final criticism. This is the most important criticism of this meta-analysis. The IST-3 trial, which is the largest TPA and stroke trial, looked at presentation after 4.5 hours, and it found no benefit, and it included more than 3,000 patients. So I asked, why wasn't IST-3 included in this meta-analysis? And if it was, there'd be almost certain no benefit found. Next topic, public reporting of procedural outcomes. In the practice of medicine, good intentions are not enough. It's hard to imagine how collecting and publicly reporting outcomes of PCI procedures is not a good thing. I mean, come on. Patients who are about to have heart procedures surely want to know the best docs and the best cath labs. Well, Dr. Rishi Wadera from the group of Dr. Robert Yeh, along with multiple other co-authors, including Karen Joint-Maddox, have published important survey data focusing on the burdens of public reporting in Massachusetts. The Journal of the American College of Cardiology published this paper. Deborah Beck has a very nice recap on this topic, and in short, the authors found 4 major findings. 1, the cost to the institution to report this data is high. The median numbers range between $100,000 and $200,000 per year. The median number of full-time people employed solely for reporting range from 0.5 to 2.75 FTEs. Cardiologists spend up to 5 to 10 hours per week on public reporting, and their perception was that the burdens do not outweigh the benefits. Now, I want to first start with some good news. There is no doubt in my mind that collecting outcomes data and reviewing cases is helpful for the internal quality of the lab. I mean, we do it at our hospital, and I think the process is extremely helpful. The problem comes when you publicly report data and use it for a quality measure. Remember Goodhart's law. Goodhart's law. When a measure becomes a target, it ceases to be a good measure. Now, the authors offer a very nice discussion of the many downsides. First, public reporting has not yet been associated with improved outcomes. Next, available data suggests that patients don't even use this data to make decisions. Third, public reporting places burdens on clinicians that distract them from caring for patients. Distraction is a huge issue. And then public reporting costs dollars. These dollars may be better spent elsewhere. We call this opportunity cost. And I think this last concern is the worst. Public reporting may induce doctors to avoid intervention in those who would benefit most, such as those patients with AMI complicated by cardiogenic shock. Lower rates of PCI in reporting states, for instance, have been most pronounced among these highest risk patients. The authors cite a recent survey of interventional cardiologists in Massachusetts and New York, and a majority, 75%, admitted to not performing high-risk but indicated PCIs due to concerns that doing so might negatively impact their public reported outcomes. And the biggest irony of this whole mess is that the good intention rush to provide transparency and data to help patients decide has an unintentional effect. And the unintentional effect may be to deny therapy to the most needy. And of course, this life-altering decision to not do a PCI would never make it into a spreadsheet. Next topic is an FDA warning on the Impella RP system. Now, I'll just start with a general statement. Before a device was approved, during pre-market studies, 73% of patients survived to 30 days. After the device was approved, during post-approval studies, only 29% of patients who received the device survived to 30 days. This is the main reason the FDA sent another Dear Cardiologist letter, which updates its February warning letter. The FDA writes that they think the much higher mortality rate after approval is due to patient selection. Now, that's because for post-market patients who met enrollment criteria, their survival was 64%, while only 11% of those who did not meet criteria survived. FDA also writes that this Impella RP system post-approval study and the FDA's evaluation are still ongoing. And I highlight this story not just because of the specifics of treating very ill patients, but it's also to highlight the problem with our approval system. What's happened here is typical. Once a well-reimbursed device gets on the market, It's very difficult to regulate or study it. So I strongly, strongly believe we need better pre-market approval processes. Think about it. Impella is used to treat patients with high rates of death. If the device is so great, it should not take that many patients in a trial to show benefit. I mean, when we use devices that cost a lot and confer significant risk, we should have strong evidence for benefit, and this requires doing the RCTs. Next topic is on grapefruit juice, and it's not one of these observational nutritional studies. This one is different. Researchers led by Sami Viskin in Tel Aviv published an interesting and important study looking at the effects of grapefruit juice on the QT interval. They used a protocol that pharmaceutical companies often use to test new drugs for QT prolongation. Basically, in their study, healthy volunteers and patients with long QT syndrome drank large quantities of grapefruit juice, up to 2 liters, in a controlled setting. Normal volunteers also received moxifloxacin, a known QT prolongation drug, for comparison purposes. Now, some quick background. Flavonoids in grapefruit juice have been shown in vitro studies to block the IKR channel, which is the delayed rectifier channel. The main findings: 1, the net increase in QT interval caused by grapefruit juice in healthy volunteers was about 14 milliseconds. This, the researchers say, is small, but if it were a drug, it would come with a call for more studies. And it was similar to the QT increase in normal volunteers who got moxifloxacin. Second finding, grapefruit juice prolongs the QT interval more in females. And thirdly, grapefruit juice significantly prolongs the QT interval up to 21 milliseconds in patients who have long QT syndrome. These are important observations because when torsade de pointe occurs in real life, it is rarely due to one thing. I like to explain the causes of TDP as akin to plane crashes. It's often due to multiple issues, like bradycardia and low potassium, or an antibiotic and an antiarrhythmic drug. This paper, these findings suggest that we should add drinking large quantities of grapefruit juice as a potential contributor to torsade. Remember, too, that some supplements contain large quantities of flavonoids similar to those in grapefruit juice. And surely for our patients who have long QT syndrome, they should avoid drinking large quantities of grapefruit juice. Of course, we should also say what we should not take from this study is that grapefruit juice is dangerous. No, that is not the case. Normal amounts of grapefruit juice are fine. Final topic for today concerns ICDs for primary prevention. Now, during the Heart Rhythm Society meeting, I went to 2 sessions that got me thinking about the expiration date of evidence. Specifically, and sit down for this, perhaps the primary prevention ICD may need rethinking. Now recall that the seminal trials like MADE-IT2 and SCUD-HEF, these trials that showed benefit for ICDs in primary prevention, recruited patients nearly 20 years ago. That was before we had ARNIs, before CRT, before the widespread acceptance of PCI for STEMIs. Now, one study at Heart Rhythm Society was a late-breaking clinical trial in which the MADE-IT investigators looked at the rate of ventricular arrhythmias and death in the old MADE-IT trials versus the more contemporary, newer MADE-IT trials. They found huge drops in the rate of ventricular arrhythmias and death over time, a temporal decrease. That's interesting. Well, then I went to a poster session from Dutch investigators who were able, using their excellent nationwide data systems, to cull the complication rates over the first year of implants for primary prevention. And they found the rates of ICD complications up to 13.5%, with major complications of nearly 8%. Now, notable is that we don't have this data in the U.S. because the NCDR data that we use looks only at the complications during the hospital admission, not the 1 year afterwards. Also notable is that this Dutch data, which shows very high complication rates, surely represents a best-case scenario because, unlike in the U.S., ICDs in the Netherlands are implanted in small numbers of selected centers. So now, stop and think. VT rates are declining. Medical therapy is better. PCI for STEMI is reducing the pool of high-risk ischemic cardiomyopathy substrate. And complication rates are surely higher than we American doctors think. So I have a column on this topic. I hope you take a look at it and maybe leave some thoughts. Perhaps, I argue, ICDs for primary prevention may be going the way of aspirin. That is, an intervention that was once effective, but because the population it's being used in is changed, may no longer be effective, and perhaps we need new data on ICDs for primary prevention. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please consider subscribing, giving us a 5-star rating or a review. That way other people can find it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.